I will be discussing today on hemostatic agents in neurosurgery. So how can we enhance the surgical hemostasis? So this is my disclosure. And moving on. So today I will be discussing the topic under the following headings. First of all, as Dr. Hassan sent me across, we will be discussing some learning objectives, then an introduction, a brief history, then how to classify the different hemostatic agents, then comes the special circumstances, and finally I will be concluding my talk. So regarding hemostasis in neurosurgery, it is not possible to include each and every aspect of hemostasis in neurosurgery in a single talk, because it will be like too elaborate for a talk, which can be covered in an hour or two. So I am excluding the following components from my talk. First of all, I will not be talking in much detail about the coagulation pathway, which is quite familiar to all of us, but I will be mentioning that once in a while during my talk. Then I will not be mentioning about the systemic hemostatic agents like tranexamic acid, factor 7, like those type of coagulation factors. Then I will not be discussing much on the management of different bleeding or coagulation disorders like hemophilia, von Willebrand's disease and all. Then regarding the aneurysm clips, Liga clips, different methods of application and all those things will be beyond the scope of this topic. Then how the anesthetist can support us with the hemostasis, that part is also I am not including. Then regarding the learning objectives, as Dr. Hassan sent to me across, so like many of these were actually new to me as well, especially like a question like is there any hemostatic agent that is contraindicated for use in brain surgery? I didn't know that till I read more about this topic. I will answer all these questions towards the end of the topic, but this will be the learning. These are the learning objectives. Then another one will be which hemostatic agent is most antigenic. Then which one can we leave safely in the brain parenchyma? Is it a correct practice to apply Surgicel to the operation area after removing the brain tumor? Then is the use of a hemostatic agent associated with the infection? If so, which one is the safest? Which hemostatic agent can be preferred in epidural bleeding and foraminal bleeding in spine surgery? Any hemostats that can be applied in endoscopic surgery? Then is it necessary to remove a hemostatic agent after the bleeding has stopped? Then do any hemostatic agents offer advantage over its competitors? And which hemostatic agent is recommended for bone-related bleeding if we do not have bone wax? Okay, coming to the introduction part. You know that in neurosurgery, immediate hemostasis is extremely important. Even small amounts of blood within the brain parenchyma may lead to a permanent neurological damage or sometimes even death. Then microneurosurgical interventions require a clear field of vision, as you know. So continuous bleeding may obscure the target structures with potential for tissue damage. Now coming to the importance of hemostasis. First of all, if there is a bleeding into the surgical site, it makes the visualization difficult. So the surgical approach will become unsafe. Next this will be associated with increased risk of intraoperative complications and inadvertent neurovascular injury. Then if there is a poor hemostasis, it can lead to a postoperative hematoma. Again, patient will have to take the theater. For these days, the challenge includes managing patients who are on multiple antiplatelets and anticoagulation therapy, especially for cardiovascular diseases. And if there is more blood loss, we'll have to transfuse blood, and this comes with the risk of infection, coagulopathy, and fluid overload. An important point to stress is whatever hemostat we are using, the use of a hemostat is not a substitute for a good surgical technique and proper application of conventional procedures for hemostasis. Now coming to a brief history. In ancient Egypt, like it is in the BC era, they started thermal hemostasis. And later on, they developed a mixture of wax, grease, and barley. Then even Hippocrates used caustic, like that is a chemical, as a chemical hemostat. Then after some time, the medical science was pretty much like remaining stagnant in terms of hemostasis. Later on, in towards the 19th century, Horsley proposed the formulation of bone wax. I will talk on bone wax a bit later on regarding that history part. Then came the electric coagulation in 1920s by Cushing and Bovey. Then different products got introduced in a sequential manner. First is oxidized cellulose, then gel form, then oxidized regenerated cellulose, then Surgiform, cyanocralates, flow seal, taco seal. Yeah, the list goes on. Now coming to the history part of bone wax. So this is something which is very interesting, because this bone wax is always known as Horsley's wax. Otherwise, we always imagine that Victor Horsley invented bone wax, which was not actually the case. Because in 1840 itself, a Russian surgeon, Christian Salomon, so he mentioned the use of bone wax for cranial bone hemostasis, and this he mentioned in Manual of Operative Surgery, which was in Russian language. And you can see that 24 years later, Henry Ferdinand Dolbeau, he was a French surgeon. He described the use of bone wax in a clinical scenario on excising an osteoma of the frontal sinus. And this he presented, actually not him, his student presented at the meeting of the Paris Academy of Medicine. And when this presentation was being held, Victor Horsley was just 7 years old. And Victor Horsley finally published his formulation of bone wax in the British Medical Journal in 1892. So he mentioned that it contained beeswax 7 parts, almond oil 1 part, and salicylic acid 1%. So you can see here, which is quite striking. Actually, maybe this got missed in the history because the language might have been Russian. At that time, most of the scientific literature was in English language. So maybe otherwise we would have given importance to Dr. Salomon. Then French surgeon, he actually just presented this. His work was only presented at a meeting. Instead of getting it published, somehow he managed to only present it. So that is why his name didn't get that much of importance as deserved. And finally, Victor Horsley got it published in BMJ, and that is how everybody knows this bone wax as Victor Horsley's bone wax. Now, coming to the different strategies of hemostasis. There are mainly 3. It is essentially 3: mechanical, chemical, and thermal. Simple. Now, there is a classification put forward by Spotnis et al. In 2012, and this is based on the mechanism of action. So it includes mechanical, active, flowable, and fibrin sealant. So these are the 4 classes of hemostatic agents. And in today's presentation, I am planning to present it based on Spotnit's classification. You can see here, mechanical includes physical agents, gelatins, oxidized regenerated cellulose, microfibrillar collagen, and micropolysaccharide hemospheres. Then active includes different thrombin products. Sealants, as you know, different types of fibrin sealants, Evisil, Tacosil, cyanocralate, and crocil. Then flowable agents include flow seal and Surgiflow. And in addition, I will be mentioning also about some coated patches. Now, coming to the coagulation pathway, I told like I'm not going to mention all the factors, but it is worth noting that the cryoprecipitate fibrin sealants, collagen, and recombinant factor 8A, this will be acting on the extrinsic pathway. And the gel form, Surgicel, and all will be mainly applying mechanical pressure, leading to vasoconstriction and hemostasis. Then thrombin directly acts here in the final common pathway. Now, do we have an ideal hemostatic agent? The answer is no, because all these properties are not satisfiable by any hemostatic agent as of now. So it should be light, stable, it should be easy to apply, flexible for wound adaptation, avoid tissue degradation, and it should withstand the pressure from bleeding, and it should be easily removed. Now coming to the first group, that is mechanical agents. These mechanical agents, they provide basically hemostasis by just mechanical support, like or mechanical action. It does not interact with the coagulation pathway or cause any type of cellular interaction. So it acts as a matrix to aid clotting initiation through a tamponade. And the products require gentle pressure to adhere. And irrigation with saline solution can dislodge the exceeding material, leaving thrombus in situ. The mechanical agents are divided into 4 subgroups, as mentioned in the first chart. They are physical agents, gelatin, oxidized regenerated cellulose, microfibrillar collagen, and microporous polysaccharide hemospheres. Coming to physical agents. So all of us know about bone wax. The rest 3 are not that much well known. Second one will be a self-setting bone wax based on polyethylene glycol and hydroxyapatite combination. Then third will be bone seal, and last will be Ostine. Ostine is a relatively new product and quite useful. Coming to bone wax, it is said to be the epitome of physical agents. As mentioned earlier, it provides barricade and tamponade and enables clot formation by stopping the blood flow. So whenever blood flow stops, there will be automatically formation of a clot. And modern beeswax, as compared to Victor Horsley's beeswax, is quite different in the constitution. It is made up of 85 to 90% of white beeswax and 10 to 15% of isopropyl palmitate, which acts as a stabilizing agent. And it is insoluble, and it remains within the site of implantation for a prolonged time, if not indefinitely. It is not absorbable. Next will be the bone wax should be immediately used after removal from the package, ideally. And after removal from the package, it can be molded in our hands, as shown here. And the optimum working temperature is said to be 21 to 23 degrees Celsius. And it has to be used only when necessary. After manipulating with hand, ideally it should be bathed in iodine. And the exceeding bone wax should be meticulously removed, because I will come in the next slide what will happen if we keep a lot of bone wax in the body. Then it should not be used at near fusion sites, especially within the spinal canal. And it should not be used when there is a contamination. There are lots of uses associated with bone wax, which I had published in a paper earlier. So basically, it can be like when you are drilling inside the skull, you can place it over the surrounding tissues to prevent the surrounding tissues from getting trapped in the drill. It can be used to prevent CSF leak after to cover the frontal sinus after anti-skull base repair. Sometimes it can be life-saving when you apply it over the foramen spinosum in case of medial meningeal artery bleeding. And yeah, there are lots of other uses of bone wax as well. Now coming to the adverse effects of bone wax. So there can be some immune reactions or like some including allergic reaction, infection. Sometimes it has even led to formation of granulomas and retarded osteogenesis. There has been reports of iatrogenic quadriplegia following spinal surgery due to the application of bone wax. Then sometimes it can lead to ptosis and diplopia, sigmoid sinus obstruction and thrombosis, skull osteodystrophy. In one case, there was migration of the bone wax into the orbit through a frontal sinus abnormality. And there was another report of bone wax migration in the left middle temporal gyrus, leading to short-term memory loss, apraxia, and word finding difficulties. Zhou et al. In their paper gave this picture, like a beautiful picture of all the different side effects associated with the use of bone wax. Now coming to bone seal. Bone seal is a novel composite of hydroxyapatite and biodegradable polylactic acid. It promotes higher amount of new bone formation compared with bone wax in porcine models. So you can see here it is absorbable, unlike bone wax. It does not wash off or dissolve. It is highly biocompatible, and it does not contain any animal tissue like beeswax or anything. and it contains hydroxyapatite. Now coming to Ostin. Ostin, the importance is it is a totally absorbable bone wax, and that also it dissolves at the implanted site within 24 to 48 hours, and it is water soluble. So it's a synthetic implant material made from alkaline oxide copolymers. So there are no animal products associated with this as well. And it can be softened by manual manipulation as with bone wax. And it actually promotes bone healing. So these are the mechanical products, especially associated related to bone wax. Now coming to gelatin. So porcine gelatin is relatively widely used in neurosurgery. We call it as gel form very commonly, but there are other products as well associated with porcine gelatin. So it's a hydrocolloid made from purified gelatin derived from porcine skin. So pig skin, the gelatin will be derived, and that is made into a hydrocolloid. It is hygroscopic. Hygroscopic means it can absorb water and it can bond tightly to the surfaces and provides a damp reticulum that will absorb blood. There are two main common mechanisms. One is it concentrates endogenous coagulation factors and it promotes platelet aggregation. And one thing you can notice always that once the gel foam is applied over a hemostatic area, so over a bleeding area, it swells up, and actually gelatin sponges absorb 35 to 45 times their own weight. And it is mostly considered non-antigenic, even though it is made from porcine skin gelatin. It undergoes so many processes before being produced as the actual product, so it is considered non-antigenic. And it should be used at neutral pH if we are using topical thrombin or other biologic agents along with it. And usually it gets absorbed in 4 to 6 weeks. Now, all of us know gel foam, but there is something called gel foam plus as well. That is a combination of gel foam and thrombin. And these are the common gelatin-associated hemostats. Now, all of us know how to apply gel foam. It can be applied in two ways. One is just dry. You cut the gel foam into the suitable size and apply it over the bleeding area and apply some pressure. Second will be, we will wet it with saline, and so we have to squeeze it with our hand, or we will have to place it between like a gauze piece and try to squeeze out the air bubbles and then apply it and apply pressure. And usually when we apply gel foam to a bleeding site, what we do is we apply the gel foam followed by a patty and then apply suction over the patty. So it is thought that when we apply the suction, the gel foam will help the gel foam to draw more blood and form a like a pressure effect on the bleeding site. But it is actually told that it is not really needed because gel foam itself will absorb some blood with capillary action, and so no need to apply additional suction. And if the first application of gel foam is not able to control the bleeding, additional application should be, we may have to cut other pieces and keep it over the original site. And gel foam may be left in place at the bleeding site when necessary. So if there is a big bleeding and we control the bleeding using gel foam, then it can be left at that place and it will get absorbed as mentioned earlier. There are some contraindications to the use of gel foam, especially under the skin. If you use gel foam, if parts of gel foam are projecting into the skin, it interferes with the healing of skin edges. Then if it goes into the intravascular compartment, it can cause embolization. Then if a person is known to have allergy to pig products, especially pig products, the gel foam is not that much safe to use in those patients. Then when we are using cell salvage techniques, then gel foam particles can get trapped into the cell salvage machine, so it is not safe. Then as a part of CSF leak repair also, it is not feasible to use gel foam. Then adverse effects, as with bone wax, it can also be associated with several adverse effects like foreign body granuloma, abscess formation, fever. Sometimes it can swell up, leading to compression of the brain and spinal cord. Then it can cause quad-equina syndrome if there is like tightening of the spinal canal. Spinal stenosis, meningitis, arachnoiditis, toxic shock syndrome, and there is a report of hearing loss in following tympanoplasty. The ENT surgeons usually keep a strip of gel foam over the tympanic membrane, so that has resulted in hearing loss in some patients. Next comes the oxidized cellulose-based products. This also is a very familiar thing for most of the neurosurgeons. So we usually call it as Surgicel. So it is actually derived from decomposed wood pulp or cotton fibers. And these are oxidized by nitrous oxide into cellulosic acid and then engineered into continuous cellulose fibers. So it again acts by a mechanical action. It provides a matrix for clot initiation and promotes platelet activation and adherence. And it does not interfere with the coagulation mechanisms. And it is a biologically absorbable material. So, but after applying Surgicel and hemostasis attained, it is preferable to wash it off or maybe take it off after some time, because what happens is if there is further contact with blood, it can swell up and forms a gel-like consistency, and it can lead to mass effect and neural compression, especially if you are working near the eloquent areas. But if there was an intraoperative massive bleeding and you attain the hemostasis using this Surgicel, then you can leave some minimal amount in that area rather than just trying to peel it off, producing another bleeding. So it is okay to leave minimal amount, but try to remove it as much as you can because it can lead to some complications. Another thing is about Surgicel is usually when we operate and you apply a lot of Surgicel over the area, and next day you look at a CT scan or an MRI scan and see some hematoma in the surgical cavity, then you always get confused whether it is a hematoma or it is the Surgicel itself. So there are some techniques to differentiate between these two. In T2 weighted image, the acute hematoma hypointensity is not as deep as that of Surgicel. It means that cellulose will be appearing more hypointense in T2 weighted image. However, a thin peripheral hyperintensity can be seen due to a postoperative fluid collection surrounding the cellulose. Now, another advantage of this is that it decreases the pH and acts as a caustic agent. So it generates coagulative necrosis, artificial clots, and tamponade. And the clot is brownish. Whenever we apply Surgicel, it will turn brownish immediately. And it is due to the formation of acid hematin. And when we apply biologically active hemostatic agents like thrombin along with this Surgicel, what happens is the thrombin will get inactivated. So it is not advisable to use Surgicel along with other hemostatic agents like live hemostatic agents like thrombin. Then the low pH will help prevention of bacterial growth. So it has got bacteriostatic agents against multiple organisms. Now, you know that Surgicel comes in, mainly we use it as mesh sheets, but it also comes in fibrillar tufts, gauze, sponges, and woven strips. Surgicel is quite easy to handle, and it is applied dry and manually compressed. It is not needed that you should wet it. It usually forms like a complex by interacting with the blood. And it forms tight bonds with the tissue, and it does not stick to surgical instruments. And sometimes after applying, if there is a bleeding in which you cannot see the bleeding point very accurately, you can apply Surgicel. I am talking about only minor bleeding. You can apply Surgicel over that area, and you can even apply cautery and suction over the Surgicel. And sometimes even bipolar can also be applied over the Surgicel. And it usually gets absorbed in 2 to 6 weeks time. Now, there are lots of uses associated with the Surgicel. It is very useful in controlling venous bleeding and oozing from the cortical surface after tumor resection. So it decreases the oozing from epidural space and slows down the formation of extradural hematoma formation. Then it aids coagulation via gentle irrigation during endoscopic surgery. So one other thing is that during skull-base surgery, during cavernous sinus region dissection, it is quite useful. Bleeding control from the anterior cavernous sinus. So it has got lots of uses in different areas of related to neurosurgery. Now coming to the adverse effects, as mentioned earlier, we cannot use biological agents like thrombin because of the acidic environment created. Then incomplete product absorption and local acidity can lead to inflammation and granuloma formation. Then neurologic manifestations from direct neurotoxicity or unintended compression by the surgicelloma. So it can swell up and cause a surgicelloma, and it can press on the surrounding neural structures. Next comes the microfibrillar collagen. So a few of these are mentioned here. One of them is avitin, and another one is lyostip. So it is actually obtained from the dermis of cow. Basically, it is raw bovine corium or dermis, or equine or goat collagen fibers combined with a salt. It provides a surface for platelet adherence and easing their aggregation, degranulation, and thrombus formation through the intrinsic pathway. And it has got the property of strong adhesion to bleeding surfaces even after hemorrhage has stopped. And it gets absorbed in 8 to 10 weeks' time. After application of microfibrillar collagen, the surfaces remain white and dry, and it does not swell. Unlike surgical and gel form, it does not swell. Hemostasis is finalized in 2 to 5 minutes, and it is effective in patients under full heparin anticoagulation. But it does not have any bacteriostatic properties, and it comes as flow, sheet, or sponge. And regarding MFC, the main sometimes irritating part is it is very tricky to handle because it adheres to wet surfaces like instruments, surgical gloves. So everywhere it gets stuck. But there are some pre-filled applicator devices like endoavitin, syringe avitin, which can be quite useful in endoscopic surgeries. And it is highly effective when applied over broad surface areas, and it is recommended to tease away the excess product after 5 to 10 minutes. These are the different formulations of avitin. Applications of avitin are more or less similar to that of oxidized regenerated cellulose, but avitin can be soaked in thrombin, unlike ORC. And as I mentioned, it can be used in endoscopic endonasal surgery. The adverse effects are immunologic reactions because it is again animal product, no bacteriostatic effect, and interferes with the normal wound healing and binds to neural structures, and it is quite adhesive, so it can bind to neural structures causing pain or numbness, and reduces the binding capacity of methyl methacrylate. It is less effective in patients with thrombocytopenia. Now comes lyostip. Lyostip is it comes as a you can see here like sheets, and it is absorbable wet stable collagen compress made of collagen fibrils of bovine origin, and it promotes platelet adhesion and activation of coagulation factor 12. It is indicated for capillary bleeding and parenchymal hemorrhages. It achieves hemostasis very swiftly. It can be removed easily. It can be applied endoscopically and can be combined with fibrin glue and antibiotics. And it has got low tissue reaction but fast absorption and good biocompatibility. It is quite widely used in endoscopic surgeries. Now, as I mentioned in the beginning, I will mention a few points about the coated patches, which are not included in the classification. So these coated patches are like one of them is hemo patch. You can see here. I'm not sure whether it is widely used, but I use it in a routine manner because I find it quite useful. So hemo patch is flexible and has got strong tissue adherence, and it is a flexible part of collagen derived from bovine dermis, and it is coated with a compound called NHS-PEG. And it is absorbable, and it achieves hemostasis regardless of the patient's coagulation status. That is very important. And it does not require any preparation or pre-moistening. And you can see there are two surfaces. One is with blue dots, and the other one is white. So we have to apply the non-marked white surface over the bleeding area, not the other way around. So this surface should be facing the wound. And it has to be held in place for 2 minutes, and it gets absorbed in 6 to 8 weeks' time. Now another patch is called Veriset. Veriset is oxidized cellulose impregnated with the buffer salts, a compound called trilysine and reactive PEG. And again, it acts as a tamponade while concentrating platelets. And it should not be hydrated prior to placement. And here also, you can see here, there is a darker side and a lighter side. So the darker side should be facing the bleeding point. And you have to hold it there for 30 seconds and get absorbed in 28 days. Another coated patch is called Evarest. It is a fibrin sealant patch, matrix of non-woven polygalactin 910. It's same as Vicryl. It's a matrix of Vicryl embedded in ORC and coated with human fibrinogen and thrombin. And here also there are two surfaces. I don't know whether you can appreciate it very clearly. This surface is actually woven and the other surface is powdery. So the non-active side is woven. There is a woven wave pattern, but the powdery side is the active side. And the absorption time is 8 weeks. Now another coated patch is Tacosil. Tacosil is a horse collagen derived product, and it will be coated on one side, and the active ingredients include human fibrinogen and human thrombin. And you can see here there is an yellow color to the active site, which is given by riboflavin. So this yellow side has to be applied to the bleeding area. It is advisable to pre-moisten it with saline solution and get absorbed in 13 weeks time. There is a recent technique for microvascular decompression in which Tacosil can be used in an effective manner. That is called bird lime technique. So bird lime means it's a sticky thing. Sometimes there are like lots of pest birds. So these are damaging the fields and all. So what the farmers do is they make a sticky material. They apply it on the branches of the trees so that the birds will get stuck onto it. So that is called bird lime. And the similar method is used here. Tacosil is rolled into a small, like a nodule type of thing, and then they are applying they are applying fibrin glue over this. So after applying fibrin glue over the Tacosil nodule, they will apply it over the petrous region where the superior cerebellar artery can be stuck on, so that the trigeminal nerve is relieved of the compression. So that can be quite useful in the management of trigeminal neuralgia as a surgical technique of trigeminal neuralgia. Next one is microporous polysaccharide hemospheres. So these are hydrophilic polysaccharide particles with a diameter of 30 to 100 microns, and they are made from 100% purified potato starch. So again, it acts by absorption of, so it basically absorbs the fluid components of the blood. So if there is a bleeding in one area, it absorbs the fluid component of the blood and it concentrates the platelet and clotting factors. So what happens? All these predominant clot promoting agents will get accumulated and it forms a clot. And it can also be used independent of the patient's coagulation status. And it comes as a fine, dry, sterilized white powder, and it does not contain any animal or human components. And it is biocompatible and non-pyrogenic and gets absorbed quite easily. And another important thing is it does not cause any tumor mimicking contrast enhancement. So we need not get confused whether there is a residual tumor or not after applying MPH. And but it does not have antibacterial property, and if there is a brisk bleeding, it is not quite useful. One product of belonging to the MPH is Arista AH. So as mentioned, it forms a molecular lattice when encountering blood. It does not require any mixing or refrigeration. So basically, you open the cap and just apply the powder directly to the bleeding site. This part I mentioned already. It concentrates the salt components of the blood. And full hemostasis is usually achieved within a period of around 57 seconds. That is quite great, less than 1 minute. And it degrades more rapidly than Surgicel, Avitin, and Floseal. and gets absorbed in 24 to 48 hours and without resulting in any foreign body reaction. But the problem is cost. 1 gram of Arista costs around $85 US dollars. Next will be thrombin-based active biologic agents. There are 3 different sources: bovine, pooled human plasma, and recombinant technology-based thrombin. So basically, they activate factor 5, factor 8, and factor 11. And the basic mechanism involves conversion of fibrinogen to fibrin clot. So if a patient has got some fibrinogen deficiency, this is not going to be useful. It promotes platelet aggregation and adherence, and efficacy is directly proportional to thrombin concentration. It can be delivered alone or along with other absorbable hemostatic agents, but not with Surgicel, as mentioned earlier. So these are the area where thrombin is acting, fibrinogen to fibrin. Now, one product worth mentioning is thrombin JMI. So the main point of mentioning this is this was of bovine origin, and it led to the formation of antibodies leading to prolongation of thrombin time and leading to hemorrhages and thrombotic reactions. So basically, it is not used in neurosurgery, and it has highly antigenic and associated with the. So the FDA put something called black box drug warning label. That means that it is not longer safe to use. It can be associated with high risk of death. Other products that use thrombin are Evithrom. Evithrom is the first standalone human thrombin preparation and achieves hemostasis within 3 minutes. But it has to be stored frozen and has to be kept in a refrigerator. If you are keeping it at room temperature, it has to be used within 1 hour. It cannot be refrozen. It aids to hemostasis whenever oozing blood or minor bleeding from capillaries and small venues is accessible. It cannot be injected directly into the circulatory system. It cannot be used if there are several anaphylactic reactions, human blood products, and it cannot be used as a treatment of severe or brisk arterial bleeding. Next comes Recothrome. It has got the identical amino acid sequence as human thrombin, and it is made from genetically modified Chinese hamster ovary cell line. So it's a reconstituted thrombin. And it has to be stored lyophilized at room temperature and reconstituted with normal saline. Main advantage is that it does not have any risk of antibody development, and it does not have any risk associated with viral transmission as seen with human-derived thrombin. After application, thrombin products may be left in place. No need to wash it off. And all standalone thrombin agents are applied as a solution. It can be sprayed into a mist or used with another carrier, as I mentioned earlier. Now comes one of the commonly used things, hemostatic agents in neurosurgery, FlowSeal and SurgiFlow. So it's a hemostatic matrix combining gelatin particles and thrombin. So it yields a stable fibrin matrix and clot through double mechanism. First one is the cross-linked gelatin particles will swell up, providing tamponade effect and conform to irregular space. So it is more like a gel form. While the thrombin activates factor 5, 8, and 13 and platelets. So these convert fibrinogen to fibrin and hasten clot formation. So thrombin basically acts at the terminal portion of coagulation cascade and effective despite coagulation factor deficiency. But if the patient has got fibrinogen deficiency, we cannot use FlowSeal because it is not going to act. And it achieves hemostasis in less than 1 minute, and both clot and product are reabsorbed in 6 to 8 weeks time. If there is some confusion in histopathology, whether there is some residual tumor or if it is FlowSeal associated with the application of FlowSeal, then the pathologist can do an elastin staining, and this FlowSeal will be staining with elastin, positively staining with elastin. So it is associated with less chronic inflammation, fibrosis, and vascularity. So what's the difference between these two, SurgiFlow and FlowSeal? SurgiFlow is made from gelatin paste made from pig source. So it is a porcine gelatin paste supplied in a pre-filled syringe, and it contains 2 ml of additional liquid. It can be either sterile saline or it can be thrombin. It's up to you to decide which liquid to use. Why are they giving this option? Because thrombin is quite expensive, and some units, especially cardiac surgeons and all, they will be directly using thrombin in a separate pack. So there is no need for this to come along with thrombin, because thrombin is anyway being used separately. Flow seal is a bovine component. It's made from cow source, and a human thrombin component is there, and it is reconstituted with saline diluent. So basically, this has bovine gelatin with thrombin. Flow seal has the bovine gelatin with thrombin, whereas Surgiflow has porcine gelatin with either saline or with thrombin. And overall preparation time is shorter for Surgiflow, and you can use it endoscopically via a blunt nosed or blending applicator. And basically, after applying to the bleeding area or oozing area, you have to apply gentle pressure with a surgical cottonoid. And again, it attains hemostasis in less than 1 minute, like MPH. Then simultaneous use of flow seal and other hemostatic agents is not associated with any improvement in long-term outcome. And after preparation, the products may be may be stored for application up to 3 hours. And the flow seal can be retained for another 5 hours more. After application, the granules will get incorporated in the clot. So whatever granules are not getting incorporated, that can be flushed off. And absorption wise, Surgiflow gets absorbed more rapidly in 4 to 6 weeks time, whereas flow seal will take around 6 to 8 weeks time. Now there are lots of applications associated with the flowable agents. So it aids in the excision of arteriovenous malformation, achieving hemostasis in the epidural plane, obtaining hemostasis after tumor removal or biopsy. If there is a bleeding from the cavernous sinus, we can use it after anterior clinoidectomy. So there are lots of uses essentially. But the main thing to note is we cannot use it. Like if there is a bleeding, you are doing a craniotomy over the superior sagittal sinus, or you are doing a retrosigmoid craniotomy, and the sinus starts to bleed. If there is a big sinus tear, you are not advised to inject flow seal or Surgiflow into the sinus, because it can lead to thromboembolic events. And but it can be safely used in the cavernous sinus. That is an exception. Then it comes with anaphylactic reactions, intracranial cyst formation, cerebral edema, and sterile fluid collection. Now comes this last group, fibrin sealants. So they consist of clustered human lyophilized fibrinogen and bovine or human thrombin. So basically fibrinogen and thrombin, with or without factor 13 and aproteinin. Aproteinin is a fibrinolysis inhibitor. So factor 13 actually cross-links with fibrin chains and stabilizes the clot formation. And again, it is made using double syringe technique and requires a dry operating field. Hemostasis is attained within 5 minutes, and it is completely absorbed in 10 days time. And it is particularly effective when applied prior to bleeding. Then it is effective in heparinized patients. That is important. It can be quite safely used in heparinized patients. We use fibrin sealants quite often, especially when there is a dural defect and all. But in hemostasis wise also, they are quite effective. More important point is it should not be used intravascularly, as it can result in embolization. Now, this is also worth noting, because this cross seal is a fibrin sealant composed of purified human products containing tranexamic acid. The tranexamic acid is potentially neurotoxic, and hence, finally, this was declared as contraindicated for use in neurosurgery. Now comes Evisil. Evisil is a new formulation of the previously available cross seal. It contains 2 solutions, human clotable protein and human thrombin. It does not contain tranexamic acid. It has minimum pre-application preparation time and is easy to use, and it can be used as a spray, leading to hemostasis in bleeding surfaces. Then TISEAL. TISEAL is the only fibrin sealant indicated for both hemostasis and sealing, as well as for use in both heparinized and pediatric patients greater than 1 month of age. TISEAL is also effective in patients medicated with antiplatelet drugs. Only TISEAL contains synthetic aproteinin, which is a clot stabilizer, and human sealer protein and human thrombin transform fibrinogen to fibrin. Again, fibrin sealants are associated with many use in addition to hemostasis. It is mainly used as a duramatous sealant It can be used in the reinforcement of vascular bypasses and nerve grafts and hemostasis in surgical field after tumor resection. Yeah, there are essentially a lot of uses. Then synthetic sealant include cyanoacrylates. So it is made by liquid monomers that rapidly create polymers in the presence of water, providing an interface that binds tissues. So it essentially leads to a physical barrier that prevents further bleeding and fluid leakage. It has got antimicrobial action as well. It acts as a microbial barrier. Once activated, the product should be applied within 5 minutes by spreading a thin layer over the desired area. And it adheres to most surfaces. And mostly cyanoacrylates are used in terms of skin closure, vascular anastomosis, like securing and all. But hemostatic action is also there, but it is not widely used. Then these are the MRI appearances of different hemostatic agents. So essentially, you can see that gel form, avitin, and Surgicel are more or less heterogeneous and hypointense to gray and white matter in both T1 and T2 weighted images, whereas flow seal is homogeneous and iso-intense to gray matter in T1 weighted images. And in T2 weighted images, flow seal is generally hyperintense and homogeneous to gray matter. I'm not sure whether this chart is really very clearly visible, but I wanted to convey you the importance, like how quickly hemostasis attained in different products. So basically, bone wax, it is essentially immediate hemostasis. And you can see somewhere around 1 minute range will be flowable agents and MPH. Whereas rest of the agents will take around 5 minutes time. Now, other agents which are used are hydrogen peroxide. Hydrogen peroxide is a powerful oxidant in liquid form, and it was previously used to facilitate hemostasis and kill tumor cells in the resection margins. So essentially, it acts by once the hydrogen peroxide is applied to blood or blood-containing area, it releases oxygen and water due to the catalase present in blood. So it results in an exothermic reaction and affects cell membrane lipids, leading to platelet aggregation and secondary hemostasis. So the advantage was that fast onset hemostatic effect and desirable tumor cell death. But the disadvantage, there are lots of disadvantages associated with the use of hydrogen peroxide. So it is not advisable to use it quite often. Essentially, 1 ml of 3% hydrogen peroxide will release 10 ml of oxygen. So it should not be used in closed anatomical spaces because it can lead to pressure-related mass effect. And damage to normal neuronal tissue can occur up to 1 millimeter outside the resection margin in tumor surgery. It can lead to oxygen emboli. It can lead to fatal pressure pneumocephalus and sometimes cardiac arrhythmias as well. Next will be a commonly used solution, isotonic sodium chloride. This can be sometimes if there is a bleeding following an endoscopic procedure like a colloid cyst excision, if it is a minor oozing from a vein, you will just keep on flushing saline until the bleeding stops. So it is actually a hemostatic agent in its own. And inside that, like if you are doing a craniotomy as well, it is quite useful. So it acts via gravity-mediated compression when surgical cavity there is a diffuse venous seepage. If it is cheap and easy to use, and sometimes when there is a bleeding, like a diffuse bleeding, you don't know the bleeding point, the assistant can flush some saline over that region, and that can help you identify the source of bleeding. And for hemostasis control during endoscopic operations in ventricular system. But the thing is, it requires patience and can give a sense of stagnation in the surgical flow. And the pressure in which the saline is applied should not be high, otherwise tissue will. Sorry, anything?
Oh, I think.
Sorry?
No one is spoken. I think Efe.
What?
Konuşan birisi yok değil mi? Is there any voice?
No.
Okay.
Shall I continue?
Yeah. Keep continue, please.
Okay. And the ideal temperature in which saline is used should be like the body temperature. Sometimes it can be adding to hemostasis if you are using it at 38 to 40 degrees Celsius, as per the latest paper published by Brotherton and Baker. Another method is a direct application of neurosurgical patties. So these are strips of cotton or cotton-like material and an X-ray resistant thread, come in varying sizes. It can be used to control venous seepage and minor arteriolar bleeding, and it can contribute to hemostasis by compression. Then I am not mentioning in detail about the cautery machines and the different types of cautery, but this is worth mentioning that because this also aids to hemostasis. First one is bipolar cautery. It is effective in controlling bleeding, especially from an arterial source, and it is the mainstay method to control bleeding during surgery. But the problem is, if you are working near the cranial nerves, you should make sure that the setting is really low. It should be a low amplitude application. Otherwise, it can lead to injury to blood vessels, surrounding blood vessels, and cranial nerves and surrounding blood vessels. Then another thing is, if you are trying to control bleeding from a venous sinus, if there is a minor injury to the venous sinus and the sinus is actually open, you have to approximate the leaflets of the open sinus with the bipolar forces before applying the current. If not applied correctly, it can lead to further opening of the venous sinus and further bleeding. And if bipolar cautery is not able to achieve hemostasis, then apply pressure and you can start using other hemostatic agents. And there are two designs. One is a standard bayonet shape design, and the other one is a pistol grip design, which is used more in endoscopic surgeries. Monopolar cautery is another useful device, especially it has got a coagulation action. Used for temporalis muscle dissection, suboccipital muscle dissection, and also for the nasal stage of endoscopic skull-base surgery. And sometimes if there is a bone bleeding, if you don't have a bone wax access immediately, you can even apply monopolar cautery over that region, and usually it can be quite useful if it is a small bleeder. And you should not be using monopolar cautery deep inside the sphenoid sinus and near the skull base where you are very closely related to the major blood vessels or nerves. A recent advance is aquamandis system. So the problem we usually encounter with the bipolar forceps is that usually there can be an eschar formation. And it can be quite sticky to the bleeding blood vessel. And once you try to take the bipolar forceps off, it will again start to bleed. So this is quite prevented by aquamandis system, in which there will be a saline passing through the electrode tip, and this prevents charring and maintains a clean tip. But the disadvantage is that you can see this is quite like a bulky handpiece, and it can be quite difficult to manipulate. And the tip is also big, and it can be less precise. Hemostasis. Chitosan is a compound which is derived from chitin, and it is essentially made from the exoskeleton of arthropods and cell walls of fungi. And it is also we don't have that much clinical data on the use of chitosan-based hemostats in brain, but it can be studies are still going on whether it can be safe to use in neurosurgical procedures. Now coming to special situations, spine surgeries. This is a chart taken from a paper written by Lehuek and Al-Elisa. It's a recent paper from 2022. So basically, the different types of hemostats usage depends on the type of bleed. So from the bone and if the type of bleed versus the severity of bleed. So if it is a minor bleed from the bone wax or oxidized regenerative cellulose or MFC, whereas you can see if there is a life-threatening bleed, you should not be applying all the ORC and waiting or MFC and waiting. You should be immediately going for a massive compression or suturing, or sometimes even need a surgical clamp. Then, essentially, if there is a minor ooze from the bone, ORC or MFC sponges are enough. Moderate ooze, MFC are flowable hemostats. Where there is moderate epidural bleeding, especially in patients with the coagulation disorders, flowable hemostats with thrombin or MFC. Severe epidural bleeds, especially in patients with coagulation disorders, flowable hemostats with thrombin or flowable hemostats made of MSC. Now coming to endoscopic neurosurgical procedures. So the different types of bleeding in endoscopic procedures can be classified as arterial and venous, low flow and high flow. Venous low flow, this is when stripping the mucosa from the sphenoid sinus, sometimes venous oozing can occur. It can be managed with warm irrigation, bone wax, and sometimes packing with hemostatic product using cotton patties. Whereas high flow venous bleeding like cavernous sinus bleeding cavernous sinus bleeding can be managed sometimes with bipolar cautery, tamponade with the gel foam and coronoid patties, and thrombin matrix sealant. Arterial flow, if it is a low flow, like a small branch of the sphenopalatine artery, then it requires careful and focal bipolar coagulation. And if it is from important arterial perforators like superior hypophyseal artery perforator, then it is better to not to apply directly bipolar coagulation. You can pack it with small pieces of gel foam and observe. Then if it is an arterial high flow like sphenopalatine artery bleeding, you can apply suction and direct bipolar coagulation, or sometimes even clipping of the artery if the artery can be sacrificed. Another thing is carotid artery injury, which is a dreadful complication associated with endoscopic surgeries. So it requires active participation of 2 surgeons and 2 suctions. Basically, they should be able to identify where the bleeding is from. Immediately notify the anesthetist, avoid hypotension. And if it is a branch bleeding, you can use a bipolar coagulation. But if it is a large tear, you can tamponade it with gel foam and a patty platelet. Or sometimes some people have even tried muscle patch. Then you have to abandon the procedure and take the patient for coiling or stent embolization if there is a pseudoaneurysm. And if there is no option for stent, but there is a good collateral circulation, you can sacrifice the carotid artery. But if there is no good collateral circulation, it would be ideal to do a vascular bypass followed by carotid artery sacrifice. Anyway, the patient has to be followed up with an angiogram. Now coming to scale, there are different types of bleedings in neurosurgery, but nobody had devised a proper scale associated with its use. But this has been recently published in 2023. So it is a neurosurgical bleeding scale according to the expert consortium. This is a German study. So bleeding is classified into grade 0 to grade 4. Grade 0 is no bleeding. Grade 1 is bleeding stoppable with simple physical means. Grade 2 depends on the area of surgery. If it is a non-eloquent area with the elaborate hemostasis, whereas an eloquent area with the elaborate hemostasis goes to grade 2B. Grade 3, local bleeding, immediate hemostasis requiring additive means, and grade 4, diffuse bleeding, immediate hemostasis requiring additive means. So there is a big chart also they have devised. So essentially, if there is a like minor bleeding, simple measures like a head and elevation, bipolar coagulation, and cellulose, collagen. Sorry, oxidized regenerated cellulose, collagen, and cotton or gelatin can be used. So and depends on the type of area where it is affected. If it is a grade 1 bleeding related to tumor, you can use bipolar coagulation. Whereas as the grade increases, maybe you will have to use a clip or a coated patch. Now coming to my experience with the topical hemostats, these are the things which I have personal experience with. So bone wax we know, like we often quite use gel foam Surgicel. Flow-Seal and Surgiflow, personally I find Surgiflow to be a little more easy to apply, and it forms like a solid type of thing which is soothing to my eyes, but I don't know whether it is actually effective if there is any added advantage in addition to Flow-Seal. Hemopatch, it is quite useful. One of my patients got a big oozing from cavernous sinus, the superior sagittal sinus following a parasital meningioma excision. And hemopatch was quite handy, and we just had to apply it directly over the bleeding area, and we could attain hemostasis in like 1 minute. Then lyostriptease, we use it quite often in the endoscopic surgeries. Then warm saline and hydrogen peroxide. Hydrogen peroxide, I don't use it routinely, but I used to use it like almost 8 years back. But now I am no longer using hydrogen peroxide. And always when we are talking about hemostasis, so it's essential to stick on to the basic principles. So it is not ideal to take a patient to the theater and produce a severe bleeding instead of planning it preoperatively. And if the tumor can be embolized, you can embolize to reduce the risk of bleeding. And patience is of utmost importance. Posture and position will always help. Permissive hypotension, anesthetist can help you. Pressure, direct pressure is quite a useful technique. And always try to dissect and identify the bleeder and apply diathermy. Now coming to future, there are newer agents being described in the literature, but none of them are not yet approved or quite widely used in neurosurgery. One is hemoblast bellows. These are purified porcine collagen with the bovine chondroitin sulfate and human plasma-derived thrombin. Other agents like polyurethane nanoparticles, graphene oxide, natural platelet-derived nanoparticles, platelet mimic. Platelet mimic are liposomes with the surface decorated collagen and von Willebrand's factor binding peptide. These were my references for this talk. Now coming to our learning objectives. So is there any hemostatic agent that is contraindicated for use in brain surgery? Are we open for a discussion now, or shall I just continue with this?
Yes, continue, please, and then
Okay.
when you finish, we will pass to the questions.
Sure. So this is contraindicated for neurosurgery because it contains high concentration of tranexamic acid, which is quite neurotoxic. Now, which hemostatic agent is most antigenic? It is thrombin JMI. As I mentioned before, it is associated with the porcine product and it has got high risk of antigenicity. Which hemostatic agent can we most safely leave in the brain parenchyma? It is MPH because it is associated with less reaction and it is quite easily absorbable. Is it a correct practice to apply Surgicel to operation area after removing a brain tumor? It is actually a controversial question because many people will prefer to keep some Surgicel because like there will be some diffuse oozing after the brain tumor removal and they find it quite confident to keep some Surgicel there. But it is ideal to remove Surgicel unless there has been associated prior heavy bleeding. In which case it is not ideal to peel the Surgicel off, but usually it is better to remove the Surgicel after operating on a brain tumor. Then is the use of hemostatic agent associated with infection? If so, which one is the safest? So yes, hemostatic agents can be associated with infection and safest, there is nothing like safest, but possibly Ostine because it gets absorbed very like quickly and MPH also gets absorbed, so it is safe to use in infection. Now, which hemostatic agent can be preferred in epidural bleeding and foraminal bleeding in spinal surgery? You can use probably MFC and flowable agents like Surgiflow or FlowSeal. But if you leave some Surgicel there is a risk of it expanding and causing neural compromise. Then any hemostatic agents easy to apply in endoscopic surgery. This is discussed. Flowable agents like Surgiflow or FlowSeal and Lyostip can be used. Is it necessary to remove hemostatic agent after bleeding is stopped with it? Can we leave it where it is? Yes, it is always better to remove the excess. Do hemostatic agents have any advantages over each other in terms of bleeding stopping times? Yes, I mentioned in the chart before. And which hemostatic agent is recommended for bone-related bleeding if we do not have bone wax? We can use a monopolar cautery or Surgicel or a flowable agent, and sometimes even application of diamond drill may be able to control the bone bleeding. Thank you very much for your patient listening.
Yeah. Thank you, Mr. Das, for the really high rich content of lecture. I learned a lot of myself. Now I'm going to contributions and questions also.
Dr. Das, can you stop your screen sharing? So
yeah,
in this case, we can see each other. Thank you.
And we can take the questions, contributions also. Dr. Uday Bharti, crushed muscle is also used as hemostat, he said. What do you think, sir?
Dr. Das, you can turn on your microphone. Your microphone is turned off. Dr. Das?
Yes. Yeah, so crushed muscle, I went through the literature. So it has been described to control carotid artery bleeding following endoscopic surgeries. But like there are only case reports on that. And in 1 or 2 case reports, it was not quite useful. So Literature-wise, I am not quite sure how effective it is, but personally, I have applied muscle patch when there was a bleeding from the like a base of the skull during open craniotomy, and I found it quite useful. And I use crush patch more in terms of CSF leak repair rather than as a hemostatic agent.
Yeah. And Dr. Suju, thanks you for your very informative lecture. What is your main difference between the electrocoagulation systems, electrocoagulation with radio frequency coagulation, and in the radio frequency systems, there is bipolar coagulation, just like electrocoagulation system. If the radio frequency system use microwaves, not electric current, how the bipolar coagulation work in the radio frequency?
Okay. So I don't know the answer, to be honest. Radio frequency coagulation is not widely used, and I don't have any personal experience either. But yeah, so I don't know the answer. Sorry.
Professor Suju, do you mean the endoscopic system?
We use in
Use
endoscopic
of
system, but there are also some others, I think. I don't know. Actually, as you know, we were in Bombay today
Yeah.
and yesterday, and I discussed with the surgeon from Uzbekistan. He described it, but electrocoagulation systems use electric current, and it produce heat, and it can be damaged to neural system. But the radio frequency system don't use the electric current, and use microwaves, and send microwaves in 1 millimeter and make bubbles in the water. And in electrocoagulation, you can see the spikes, lights, small
yes,
lights.
yes.
And I ask in this question, so how does it have bipolar coagulation in radio frequency? Also, he stopped and thought a little bit, and then he said, I don't know. So I wanted to know.
Yeah, it is like it's a relatively new thing, and I didn't prepare much on the coagulation part because my topic was on hemostatic agents.
Yep.
So yeah, I am sorry, I don't know the answer.
Me neither. Also.
Okay. And Dr. Yunus Aydın had also a contribution. He said fat graft application sometime he used in the spinal epidural area, and it is useful.
Which one? Sorry.
Fat graft.
Fat graft.
Okay. Yeah. Fat graft is sometimes useful, like especially it will prevent the fibrosis related to the bleeding and all. And as a hemostatic agent, I don't know whether there are many studies on fat graft as a hemostatic agent, but I believe it has got some action, and I also find it personally useful. Yes.
Thank you.
Professor,
Is
would
there
you like
any?
to add something, a few sentences? You can turn on your microphone.
Okay, hi. Hi, everyone. It's a really didactic lecture. Thank you very much, my colleague. Fat graft, I use spinal operations in the epidural space. It affects probably at the beginning the mechanical, especially the lateral side recessed parts. It helps to prevent, to stop the bleedings from the venous vessels, not for the arterial, sure. Yeah. And I applied it also as an anti-adhesion barrier at the epidural space. especially after decompressive spinal canal surgeries. In long term, when we have MRI, still it stays there and it's visible on the MRI. And we made a publication about this for using the fat graft application in spinal epidural area, like probably less than 2 years ago. But flow seal, one month ago, I go frequently. I join my American colleagues operations, and they are using frequently flow seal. They recommend the flow seal, but this is very helpful topic. Thank you for choosing this topic for everyone. Thank you.
Thank you for your
Professor Aydın,
contributions.
Yep. Madonna, I want to speak, I think. Madonna.
Yes, thank you. Thank you, Professor Das, for the amazing lecture. I've learned a lot. I had no idea there were so many hemostatic agents that we could possibly use in a lifetime. I have one question. If you have any experience in pediatric neurosurgery, if there are any hemostatic agents that are contraindicated to be used in pediatric neurosurgery, or if so, which ones and which ones are considered to be most safely used in children?
Yeah, so that's a good question. So regarding pediatric neurosurgery, the important thing is we are working in a confined space. So anything which is likely to expand is not advisable. And it is always better to use an absorbable bone wax substitute like Osteen, because we don't want the bone healing to be impaired at any point in pediatric patients. And so we will, it will better to avoid gel form and Surgicel. Even if you are applying, it is better to take it out after the application and the hemostasis is attained. Perhaps we can leave MPH in situ. So that will be my advice for pediatric patients.
Thank you so much.